following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
Welcome to Doctors on Call. Tonight's topic, neuromuscular disorders. Two experts are here to answer your questions. Now here's your host, Dr. John Phillips.
Good evening. Muscle and nerve problems such as ALS or Lou Gehrig's disease and muscular dystrophy can be difficult to diagnose. In fact, many people with neuromuscular disorders are misdiagnosed. Others suffer for years without knowing what their problem is. What are the symptoms of a neuromuscular problem? How is it diagnosed? What are the treatment options? We'll get the answers to those questions and more tonight from our two guests, Dr. Lori Gutman, a neurologist at WVU and director of the MDA Clinic, and Dr. Lud Gutman, also a neurologist at WVU and Lori's father. If you'd like to ask a question, give us a call. Our phone lines are open now. Lori, we'll start with you. Neuromuscular disorders is a huge category. Can you tell us a little bit what exactly we're talking about?
Sure. Neuromuscular disorders encompass diseases that affect the nerves, the muscles, or the way the nerve and muscle talk to each other. So it usually results in weakness, muscle weakness being the primary symptom, but it could also be sensory loss, numbness, tingling, maybe the prominent symptom or at least part of the story.
Okay. And now let's specific disorders that would fall under that category?
Well, they can be as common as carpal tunnel syndrome, which seems to be everywhere. Patients with diabetes, another very common disease, will have peripheral neuropathies. It can be as rare and unusual as Lou Gehrig's disease, which is also known as ALS, or some of the muscular dystrophies, such as Duchenne muscular dystrophy and myotonic muscular dystrophy. So it covers, as a group though, the neuromuscular diseases are very, very common. They are all over the place. Okay.
And so you mentioned weakness as a symptom. What are some other symptoms that you may see with neuromuscular disorders?
Well, the weakness can be just not arms and legs. It can be swallowing problems. It can be double vision. It can be a droopy eyelid. It can be speech problems. You can also have sensory loss, so you might have numbness in your feet, numbness in your hands. You can have, for some of the peripheral neuropathies, actually pain is a major component, and that can be the most troublesome thing and what brings the patient in. In addition, you can get breathing difficulties with some of these diseases. You can get heart problems with some of these diseases, so not just the skeletal muscle, but also your heart muscle can get affected. So. Wow,
so that's just a bunch of symptoms. And we mentioned in the opening that sometimes you could go years without knowing you have a neuromuscular disorder. Why is that? Is it the subtlety of the symptom, or?
No, it may not. The symptoms may not be subtle at all. It is related to the fact that the individual diseases may be rather rare and unusual. And for example, the myotonic dystrophy, which most people and many doctors have never seen, is a disorder in which patients have difficulty letting go of objects. Well, if the patient says that, that may not mean anything to a physician. I vividly remember a patient with myasthenia gravis who I've taken care of for the last 40 years, who presented at age 17 with difficulty blowing the trumpet during band practice. And when she went to the doctor, she had no weakness to explain that, so they promptly sent her to a psychiatrist, where in fact she had myasthenia gravis.
Yeah, and the other thing is that a lot of physicians don't get much training in the area of neuromuscular diseases. In neurology, some physicians in their training don't get any neurology exposure, and most people get just a small amount. So it's sometimes the luck of the draw if they ever see any of these neuromuscular disorders when they're working in the clinic with a neurologist during their training. So many of them will see their first neuromuscular disorders in practice where there's nobody to sort of guide them. And so that can make it difficult.
Okay. We're talking about neuromuscular disorders with the Gutmans, Dr. and Dr. Gutman. If you have any questions, please give us a call. So if a patient has a symptom, what are some of the testing that may be ordered?
There's probably the most important things that we do is getting the history. So getting a good clinical history. Like Lud was talking about, the story about blowing the trumpet was important. When you examine the patient, they might not have any weakness at the moment that you're examining them. But if you take the history and you find out that what happens is as she blew the trumpet, she got weaker and weaker, and that tells you that the weakness was fatigable. So that history is very important. And so knowing how to take the history for a neuromuscular disorder is one thing. And the second thing is the clinical exam, so knowing how to examine a patient. Once you are suspicious for it, there are other tests that you can do depending on the disorder. You can do electrical study of the muscles and nerves, an EMG. You can do a muscle biopsy. Sometimes we do nerve biopsies as well. There are blood tests that can be helpful that are specific for certain disorders.
Yeah, so not only the diagnosis, but the treatment really depends on what abnormality that you have.
Yeah. In addition to what Lori said, what is evolved in the last few years is all the genetic testing. Right. And the real problem with the genetic testing is that it tends to be very expensive. And a number of the insurance companies and Medicare are not very happy about spending thousands of dollars for genetic tests, particularly if it's a disease for which there is no specific treatment.
So are some, having the genetic knowledge, are there some diseases that can be cured and some that can? And is that why you'd want the genetic testing? Or is it just to be able to tell you what your risk of passing them along to your children are?
At this point, for most of the diseases, it's a matter of being able to identify the disease, which for the patient is oftentimes the question they want answered the most, or at least first. What is it that I have? And so if the genetic testing can be very specific, such as in Duchenne muscular dystrophy, and there, like I said, the clinical history and the exam will point you in that direction. And now, many times, the pediatric neurologist the next step is, when they're suspicious, just to go to the genetic testing. It's less traumatic for the child. It's a definite answer, and so that way you know what's going on. Most of those diseases don't have treatments. Some of them do. But the other thing is, you may not be able to cure them, but you can at least then know how to approach people so that you keep their quality of life good and keep their lifespan as long as possible.
And the fear, not knowing what the genetics are, can be very frightening. It can be very reassuring to tell a patient with a serious muscle disorder, for example, that there's no chance that he can pass that on to his children. Sure. Or to tell him, there's a 50% chance of passing it on. That's important information.
Absolutely. Well, we have our first caller. It's Teresa from Upshur County. Teresa, welcome to Doctors on Call. Do you have a question?
Yeah, I've been having severe headache, and my eye went closed, and they've been putting Botox around it, and it won't stay open, and I have muscle spasms. And they're going to do an MRI and stuff. I'm doctoring in Morgantown, and I was wondering, do they know if it could be caused by, like, the nerves or whatever?
So headaches and then eyelid.
What kind of spasms do you have?
It's like in my face. It wants to draw, and I get severe headaches, and my eye won't stay open, and...
Is the drawing just on one side of your face or both sides of your face?
Just the one side.
Well, it would be very helpful to see you, but I'm going to take a guess and make a diagnosis for you. It sounds like you may have hemifacial spasm.
Is that why they gave you the Botox? Or maybe,
Yeah.
Yeah.
So
But that sounds like that's what you have. That is a disorder in which the facial nerve is being, and that's the most common cause, is that the facial nerve, right after it leaves the brain, is being irritated by a blood vessel that's lying up against it. You can treat that specifically, but that ends up being a big surgical procedure, whereas the Botox treatment is much easier to do.
The concern is the pain that she's having with
Yeah.
it. So then she said she's getting an MRI. You said you're getting an MRI, and that's the appropriate thing to do to make sure there isn't anything else that's going on.
Right.
Usually hemifacial spasm is not a painful problem. It's just a hyperactivity of the nerve due to most commonly the blood vessel.
Okay, well, Teresa, we wish you the best of luck with that. Our next caller is Hillary from Fayette County. Hillary, welcome to Doctors on Call.
Thank you.
Go ahead with your question.
I wondered what progress has been made in understanding the causes and new treatments for ALS.
At this point, as you know, we don't know what the cause of ALS is. There's been a lot of information in the press about, is it from trauma, after the recent study that was done on a few brains and spinal cords of a few athletes who had died, who had ALS. And so the question is, does trauma play a role? Are there other things in our environment that play a role? We do know that about 5 to 10% of the patients who have ALS, it's hereditary, but that's a very small number. So that leaves you with a large number of patients that we don't know the cause for. Right now, there's a lot of interest in looking for potential causes, but there's more of a push for trying to find treatments. And there's one treatment that's FDA approved that is sorely inadequate. It prolongs life by maybe 3 months. And that's not really a very helpful treatment either. We don't know what quality of life is with that. So the other treatments that are being studied, there's currently 2 ongoing clinical trials looking at different ways to approach. The thought is that maybe there's a problem with the motor nerves in the spinal cord, that there's enhanced death of those nerves, and we don't know what causes it, but once it gets started, we try to stop the treatments all try to stop that cascade so that all the motor neurons don't die, or that at least you slow down that death.
Is the treatment medical or physical therapy?
It's mostly medical. I mean, so these treatments that they're trying in the clinical trials are primarily medical. Right now, our treatment approach is to approach it from a multidisciplinary focus. So you get physical therapy, occupational therapy, the pulmonologists are usually involved, dietitians, speech therapy, all trying to make sure that the patient stays safe, their quality of life is good, and going to multidisciplinary clinics is probably one of the best things that you can do if you have ALS. They're all over the country. So,
And that's really a relatively recent new approach in the last 10 years.
There was a paper actually in 2008 that showed that if you go to a multidisciplinary clinic with ALS, your survival rate is longer. So it truly does make a difference to try to, it used to be a diagnosis you'd give people and then you'd just say, you have ALS, you might as well go home. We don't have a treatment. Now we know that we can make a difference. So
Well, at the risk of sounding philosophical, that really is our job as physicians, to help people through life. None of us have a permanent lease, and the patients with ALS come to the multidisciplinary clinic faithfully because we really make an effort to help them deal with every little problem that they have that's related to the disease. And I think we do a good job of it. And I think other multidisciplinary clinics that deal with ALS do a good job with it.
So would that be similar to Muscular Dystrophy Association doing the same sorts of things? Obviously the two diagnoses are different, but...
So the Muscular Dystrophy Association, we have the MDA clinic for the state right now, and the Muscular Dystrophy Association supports the clinic. So that's a really important thing, that nationally they support clinics, which is very helpful to patients. They also do a lot of information, spreading information for patients, so they connect with the patients. They give them lots of information about research, so to keep people up to date. So it's really important for these patients to get registered with the MDA so that they can be sort of on that information highway, so they know what's happening for their diseases. In addition, many of the MDA sites, the offices have loaner closets for equipment. So, the equipment costs so much, and maybe you just need it for a short period of time, and then you move on to something else. So to buy it, the insurance company maybe buys you one thing, but then they won't buy you the next thing that you need because you've used up your money. So it's very nice. The MDA will try to fit people with motorized wheelchairs, walkers, from one end of the spectrum to the other.
They've been just wonderful for my patients with all the things they loan them, because many of our patients have enough of a disability that they don't work and don't have insurance, and some of these items are very expensive, and MDA does a tremendous job with their loaner closet.
The web is the place to go?
Yeah, for MDA, you can go on the web. It's www.mdausa.org. I know it by heart, isn't it? But when you go there, you can actually put in your state, and it'll tell you where the closest, or your zip code, and it'll tell you where the closest MDA clinic is to you.
Okay, excellent. We have another caller. It's Teresa from Marion County. Teresa, welcome to Doctors on Call. Go ahead with your question.
Yeah. I've been diabetic for 49 years. I've been diagnosed with nerve damage. But I've noticed the last couple of years I can be standing still and all of a sudden just start leaning one way or the other, like lose my balance. And I've never done that before. Usually I'm pretty sure-footed and stuff.
What do you guys think about that?
That could certainly be from a nerve problem. So one of the things that happens with the peripheral neuropathy, so the neuropathy, nerve damage that can occur with diabetes, is you can lose your position sense. So you can't tell where you are in space. We have three primary ways of looking at position. One is our cerebellum, the back of the brain. The other is our eyesight, so where you're looking, and the other is where your feet are, telling where your feet are in space. And you can lose one of those and be pretty good. So you can still keep your balance if you lose the feeling in your feet. But if you turn out the lights and you don't have the feeling in your feet, then you're really going to lose your balance. So one of the questions I asked, which I actually learned from him, was if you have your balance, I did learn a couple things from him. So if you're okay standing, but you shut your eyes in the shower and you start to lose your balance, or you turn out the lights at night, get up in the middle of the night, and you really feel off balance, it probably is something like your neuropathy. So.
Interesting. So, Lud, you've written a book called The Immobile Man, and it tells some stories about the patients that you've seen through the years. You want to talk a little bit about that?
Sure. The book is really not for doctors. It's a series of short stories, and it's really written for patients and for their families and for the general public. A number of the stories are about neuromuscular diseases, and the one that I probably quote the most is because patients are always asking me, well, what does the future hold and how are we going to deal with things when they get worse? And this particular story is entitled Never Saw It Coming. It deals with a rare disease of muscle, but the problem is this common one that I'm talking about. The wife spent 20 years, every visit, just worrying about how she was going to cope with taking care of her husband as he got worse, and when he got to the point where he might be an invalid. And she just worried all the time about that. And that's not the way the story ends. He never gets there.
Okay.
So there was a real message there, and the message was live life one day at a time and don't worry where you're going to be 20 years from now.
All right. Well, fantastic. Well, Karen, after taking that advice, Karen from Webster County is on the line. How can we help you tonight, Karen?
Yes, I have spasms constantly, can't sleep, and been spasmatic for 10 years. And I think they blame it on the cholesterol. I'm on 2 cholesterol medicines, and they keep up and down me on these cholesterol medicines, but it only uses spasmatic.
So you're not on a medication, you're just on a cholesterol medication?
Yes, sir. Altogether, I'm 145 milligrams.
What cholesterol medication are you on?
I'm on Zeta, 10 milligrams, and I'm on Triple X, 135 milligrams.
You're not on anything like simvastatin, Zocor, Lipitor?
I've been on all those down past, and they took me off of all those and put me on these 2 new ones and tried me.
Right. Well, with the triptans, which is a group of drugs, including Crestor, Lipitor, Zocor, muscle pain is a very common symptom, and once the symptoms are there, you would think that stopping the medicine would stop the symptoms, but it doesn't work that way. The medicines have somehow set a cascade in motion that may last for several years. Even the abnormalities in the blood, the creatine kinase or CK, which is often elevated, may stay elevated for a prolonged period of time. Yeah. So you end up having to treat the problem symptomatically with a variety of drugs like Neurontin or amitriptyline, which are two examples of drugs that may be helpful.
Are spasms common, though? It sounds like Karen's suffering from the spasms. Is that a common side effect of
spasms themselves are not? No, it's usually muscle pain and weakness is more the issue. The thought is that somehow the statins may be affecting the energy production in the that's one of the thoughts, energy production, so that's called the mitochondria, so that could happen. The other thought is it may disrupt membrane structure, and so you get leaking of the muscle enzymes from the muscles. But it really, I think when statins started to be used more commonly, it wasn't really noticed as a significant problem in the initial trials, but when it started to be using more commonly, and now we use it even as stroke prevention at this point for some patients, and we started seeing a real increase in the number of people who had these symptoms. And then, you would stop the medicine and you'd think, okay, stop the medicine, the patient should get better. And then we started seeing all these patients 6 months later, they're still having symptoms, their muscle enzymes are still elevated. And so the neurologic community, the neuromuscular community really learned a lesson because it wasn't going to go away that fast. It really can hang around a long time.
Right. But it will eventually go away.
Some people are almost always left. Some people are left with a little bit of pain that just doesn't seem to go away.
Okay. In the last 30 seconds, real quick about spasms. Anything in particular that Karen may want to think about, since it doesn't appear to be?
Sometimes the drugs that Lud was talking about, Neurontin especially, can be very helpful if there's spasms as well. So.
Okay, very good. Well, we've been talking about neuromuscular problems with the daughter-father team of Dr. Lori Gutman and Dr. Lud Gutman.
I think it's father-daughter.
Not today, it's not, Lud. Thank you both for being with us. If you'd like more information, talk to your family doctor or visit our website at wvuhealthcare.com. For Doctors on Call, I'm Dr. John Phillips. Good night and good health.
Join us again next time for another edition of Doctors on Call. Our topic, shoulders, arms, and hands.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.